Thank you for attending Summit Healthcare's preoperative total joint replacement class. So we'll start off by going over total knee replacements. You can see on the top picture, there is an arthritic knee. You can see the top bone, the femur, has all kinds of rough, bumpy bone spurs, and the bottom bone is the tibia, and it's rough and bumpy as well. You can also see where there's the meniscus in between the top and the bottom part that is severely degenerated. On the bottom picture, you can see that rough, bumpy arthritic bone has been replaced by nice, bright, shiny, smooth metal. There's a piece on the top, a piece on the bottom, and then a hard plastic piece which helps act as a cushion between the two bones. In order to access the tibia and the femur, there's going to be incision that's made along the inside of your kneecap, and then that will be moved out of the way. The underside of your kneecap a lot of times has arthritis as well. Some surgeons will just try to clean up as much of that arthritis as they can. If it's not, quote, clean upable, which is a very technical term that I've made up, it will be replaced by a plastic button. It's the same material that's made of the cushion between your top and your bottom bone. You will still have your original kneecap though, just the underside will be resurfaced. When they are finishing up the surgery, they will sew that tendon back together near your kneecap. But because there was an incision there, it is going to make it harder for you after surgery to contract your thigh muscle and lift your legs. And we're going to talk about ways to help mitigate that in just a little bit. We're going to go over total hip replacements. We have surgeons that use both the anterior and the posterior approach. Both of the incisions, though, no matter which approach that you have, it's going to be on the outside of your leg. So just so you're aware of that. That anterior and the posterior part come with how they actually access the hip joint once they get to it. As you can see from the top picture, that's a picture of your pelvis, which forms the socket part, and your thigh bone or your femur, which forms the ball part. The socket part, all that rough, bumpy arthritis is going to be removed, and there is a metal piece that will be affixed into the socket. It depends on how tight of a fit that they have. The surgeons may choose, say, I've got a really tight fit, I'm going to leave well enough alone, or they may say, I want to stabilize this a little bit more, and they may choose to use 1, 2, or 3 screws. You may also notice, it's kind of hard to tell in the picture, but that metal part is rough. And what that will do is that allows actually bone over time to grow into that, so it really stabilizes that socket part. The inside of the socket part is lined with that hard plastic piece as well. The stem, or the femoral component, the ball part, most of the time is made of a ceramic material, and there will be a metal stem that does go down into part of your thigh bone. Total ankle replacements. So total ankles are a little bit trickier to access the actual bones of the ankle. So there will be part of a bone on the outside of your leg called the fibula that will be cut and it will be removed so that the surgeon can access your actual ankle bones. The ankle bones will once again be replaced with metal and resurfaced with a hard plastic piece in the middle. That piece of fibula that had to be removed so they could access it will be reattached with different plates and screws. But because of that, you will not be allowed to put weight on your ankle for several weeks, usually 6 to 8 weeks after surgery, for that to all heal. When we talk about total shoulder replacements, there can be a traditional total shoulder replacement or a reverse total shoulder replacement, and we're going to talk about both. The traditional is the picture on the left where you can see the ball and the socket remain the same mechanics, and that is performed when people have a lot of shoulder arthritis but still have an intact rotator cuff. However, a lot of people that have pretty bad shoulder arthritis no longer have an intact rotator cuff, and the surgeon does not think that the rotator cuff can be effectively repaired. So then they will switch to what's called a reverse total shoulder. And that's a picture on the right. And what that means is that the ball and the socket are flipped mechanically. So you can kind of see that the socket now becomes from the ball and vice versa. And the reason that they do that is it changes the mechanics of your shoulder. So now the muscles that primarily going to move your shoulder around, particularly overhead, are your deltoid muscle. That's the muscle where you get your flu shot every year, that one up there. So it changes the mechanics of the shoulder. So it is important to know which surgical procedure your surgeon is going to do, but if you no longer have an intact rotator cuff, it's most likely going to be reverse total shoulder. So I get a lot of questions after surgery, and one is, will I be heavier after surgery? The answer is yes. Unfortunately, the metal that's replacing the bone that was removed is a little bit heavier. Also about metal detectors. So the answer to that is it depends, but most of the time you will set off the metal detectors. You might be able to sneak through every once in a while if they don't have them set very sensitive that day, but expect if you're in an airport or someplace with a metal detector to kind of get pulled to the side and they'll want to wand your knee, your shoulder, your hip, your ankle down. I've also included in these handouts for you a book, and it's called the Guidebook. And I'd like you to really make sure and read all of that. There's a lot of great information in there about how to prepare for surgery, what to expect after surgery. It's got all your exercises in there, a lot of great information. I've put a little post-it note on the page that I'd like you to refer to right now, and that is your preoperative exercises. I would like you to start doing these exercises as soon as you can before surgery, preferably 2 to 3 weeks at minimum. So if there is such a thing called muscle memory. So if you start doing these exercises now, it's going to really help you post-operatively because your brain and your muscles have learned how to communicate. Your muscles know what is expected of them and how to move. And it will also really help you get the particular muscles that you need stronger ready for surgery. Knee replacement patients, I talked about how we had that incision along the inside of the kneecap. These exercises, particularly the one that says straight leg raises or looks like a leg lift, that's going to be really important for you to do. So I highly recommend you start these as soon as you can before surgery. I am realistic though, and I know you all have arthritis or you wouldn't be having surgery. So please don't do these on the floor because then you got to get off the floor, which can be a challenge sometimes. Doing them in a bed, a chair, a couch is totally fine. I also realize that you may not be able to go quite as far or do quite as many because of pain and arthritis. Please do what you can, even if you can't do all of them, because this will really help you. So in order to get your house ready for when you come home, we recommend a few different things. You've probably figured out already that it's much easier to get out of a chair with armrests on it than one without, but please don't use one with wheels on it, like an office chair or some dining room chairs have wheels. That could be a little bit dangerous because a chair could get away from you. A recliner is completely fine. You won't need a special bed after surgery. I will say though, if you have a bed that's really, really low to the ground or that's really high, that may be a little bit more challenging for you post-operatively than kind of a standard height bed. If you have either a really low or really high bed, make sure and let our therapy staff know so they can practice with you before you just are discharged from the hospital. All of you, except shoulder patients, will be going home with some type of assisted device or a walker. We highly recommend that you get any throw rugs that are in your home up and out of the way because it's really easy to get tripped up on those, and I don't want you to take a fall. Shoulder replacement patients, even though you won't have a walker or something like that, you are going to have this big sling on, and it's going to be really hard for you to see your feet and much easier for you to get tripped up. So we recommend that you remove those throw rugs as well. If you have more than one step to get into your home without a handrail, if there's any way that you could get handrails installed, that's going to make your life a lot easier. If not, once again, please let the therapy staff know so that they can practice doing stairs without a handrail with you before you leave the hospital. If you are the cook of the family, particularly shoulder patients, you probably want to make sure there's some meals that are frozen ready to go in the freezer. I've also provided for you one of the handouts a little bit later. It's called the Community Resource Guide. It has the phone numbers for Meals on Wheels as well as Mom's Meals, which are frozen meals that can be delivered to your home. So if that's something that you may think you might need a couple weeks after surgery or something, you've got that contact information. If you have pets, you'll most likely be in the hospital overnight. So please make sure that someone is available to take care of your pets. There is some medical equipment that will also make your life so much easier for when you come home. You may want to consider things such as a raised toilet seat or a shower chair or tub transfer bench, along with handheld shower attachment. And for ankle patients, a knee scooter is going to make life a whole lot easier for you. Unfortunately, these particular items, most insurance companies will not cover. So you may want to consider if you have someone that you can borrow it from, because you're not going to need it for a real long time, or you can try like the Goodwill, VFWs, St. Vincent de Paul Society, Goodwill. You can try all of those different types of places to see what you can find. But I'll tell you, particularly the raised toilet seat and the handheld shower attachment make life so much easier for you. So preparing for surgery, there is a special soap that we want you to use before surgery. It's called Hibiclens, and I provided you with instructions on how to use it. You can get this soap at any pharmacy, Walmart, Walgreens, CVS, Safeway. It's a mint green bottle, and if you're going to like Safeway or Walmart, it's in the pharmacy section. You don't need the big bottle, the little bottle's totally fine. You want to use this soap at minimum the morning of surgery. If you have really sensitive skin, you may not be able to tolerate this, but if you can use it for a few days before surgery, that's preferable. This helps kill bacteria on your skin to help prevent post-op infections. You basically want to use it like soap, but don't use it on your hair or your private areas, and then don't put any lotions or anything on after that. We also recommend that you have clean sheets on your bed for when you come home. That's another way to help prevent infection. The other thing is please do not shave your legs or your underarm area for shoulder patients for a few days before surgery. You might be thinking, oh, I'm going to have surgery on my knees, so I'm going to shave it really nice so the tape doesn't stick and things like that. But when you shave, you could get a nick that you don't even see that could be a place for bacteria to enter your system and could lead to infection. So the preoperative nurses will take care of removing any hair from that area where you're going to be having surgery right before you go into surgery. Also, please don't have any fingernail polish on your fingers. I don't want you to go out and spend all kinds of money on a manicure right before surgery and then we just have to remove your nail polish. Nail polish interferes with the machine that reads your oxygen level, and it's going to beep and it's going to drive you nuts. So please, no nail polish. Pedicures are totally fine though. If you want to have nail polish on your toes, that's okay. It's just your fingers we're talking about. I want you to refer to the handout entitled Medications to Stop Before Surgery. It makes sense that you would want to stop any medication that thins your blood before you go into the operating room, right? Thin blood in the operating room is not a good combination. So on the handout, I will listed the prescription blood thinners for you and when that you need to stop them before surgery. However, there are also a lot of over-the-counter medications and supplements that have blood thinning properties. So anti-inflammatories, which a lot of people with arthritis take, have blood thinning properties. So it's things such as Aleve, or also called naproxen, ibuprofen, Celebrex, meloxicam, all of those have blood thinning properties. So we really want you to stop those a week before surgery. We also want you to stop most supplements a week before surgery because a lot of them also have blood thinning properties, particularly oils. fish oil, flaxseed oil, CBD oil, other supplements that have anti-inflammatory properties such as turmeric, things like that, all need to be stopped a week before surgery. It is okay to continue to take a multivitamin, vitamin C, calcium, magnesium. Those are okay to continue. Otherwise, I would recommend that you discontinue all other supplements. What to bring to the hospital. So we want you to bring some loose fitting clothes. Knee patients, if you could bring shorts or some real loose baggy pants that we can easily pull up above your knees so we can see it, that would be great. Hip replacement patients, I highly recommend something with an elastic waistband. So if we need to see your incision, it's just kind of easy to access. Ankle patients, just something that's nice and comfortable for you. Shoulder patients, I highly recommend a button-up or zip-up shirts. They're going to be a lot easier to get in and out of than something you have to pull over your head. Please bring any undergarments that you like, or if you have any particular toiletries, things like that you prefer, please bring that. If you have dentures, please bring those or glasses. Also, please bring a pair of shoes. And if you're anything like me, I no longer have anyone's phone number memorized. So you probably want to bring your cell phone so you can let everybody know how well you're doing, because they're going to be curious. Your friends and family are going to want to know how you are. Please bring your guidebook because it has your exercises in it. If you have a walker for hip and knee or ankle patients, please bring that to the hospital because we will use it and our therapy staff will make sure it's set to the right size and everything for you. If you don't have a walker or you can't borrow one because you're just going to need it for a couple weeks, that's okay. Our case management department will make sure that you have a walker before you leave the hospital. Total ankle patients, though, just a reminder, those knee scooters are going to be a lifesaver for you. So you probably want to make arrangements to have one of those picked up before surgery. If you have a CPAP, you know what that is. Please bring it to the hospital. We will use it so you get a better night's sleep. But please leave your cash, diamonds, gold, medications at home. Unless you take a medication that's really unusual or kind of hard to find, you can bring that one to the hospital, but otherwise we'll make sure that you have all the medications that you need while you're in the hospital. So when you come into the hospital, you're still going to be screened for COVID, at least at this particular point in time. That may change. That's just the questions that you get everywhere that you go. But please do not eat or drink anything after midnight before your surgery. If you eat or drink anything, the contents of your stomach can end up in your lungs when you're in the operating room, and we don't want you to get a pneumonia. So please be safe and don't eat or drink anything, because I really don't want you to get to the hospital the morning of surgery and your surgery get canceled because you cheated a little bit, okay? There will be a preoperative nurse that will call you before surgery. It may be a few days before, it might be the day before. They're going to go through all of your medications and your medical history. They will tell you what time to report to the hospital, and they'll also tell you what medications to take the morning of surgery with a sip of water. A lot of times it's blood pressure medications and things like that. If you have advanced directives, please make sure that the hospital as well as your doctors have a copy of it. I'm a huge fan of advanced directives. I think everybody needs them because you never know when you could be involved in a car accident or something crazy happen to you. It's really a gift to you as well as a gift to your family. If you have them and they're in a lockbox and nobody can get to them, they're not doing you any good. So please make sure hospital has a copy and your doctors as well as different family members have a copy as well. Then you're going to go back to the pre-op area after you get to the hospital, and you're going to see this packet of wipes and a body diagram. And it's going to tell you you're going to use this wipe to wipe this arm, this wipe to wipe this leg, this wipe to wipe your private areas. You're also going to see this packet of swabs, and you actually stick these swabs up your nose, and this is to kill any bacteria that's in your nose that you could be breathing on your incision. It's not the most comfortable thing in the world, but it's not too bad. I just kind of like to warn you it's coming. You're going to get in a hospital gown, and the nurse is going to start an IV and start some IV fluids, as well as give you your first dose of IV antibiotics. You're going to get a total of 3 doses of IV antibiotics, 1 before surgery and 2 after surgery. The anesthesia provider is going to come in and talk to you about the anesthesia plan. The anesthesia provider can help you with 2 different things. The first is anesthesia, which is performed in the operating room. For our lower extremity patients, so hip, knee, ankle, we usually recommend that you have what's called a spinal block, and that is where they put numbing medication from your waist down. However, they also put you to sleep, so you don't know what's going on during surgery. So I don't want you to think that you're going to be hearing the doctors talking or any machinery running or anything. But it's a little bit easier for you because what they use to make you go to sleep is a little bit easier to metabolize than general anesthesia. And the spinal block also helps with post-op pain control. If you have a really bad back or have had spinal surgeries or a lot of arthritis, they may not be able to do a spinal block. If you're like me and a little bit scared of needles, if you're a little bit anxious about that, just ask the anesthesia provider for some I don't care medicine, and they can help take the edge off a little bit for you. Shoulder patients, unfortunately, numbing you from the waist down isn't going to help you at all. So you will have what's called general anesthesia. And with general anesthesia, they will stick a tube down your throat to help you breathe. But it's not like in the ER shows where they stick the tube all the way down. They actually have this nice soft mask that goes at the back of your throat to help you breathe. But you can have a little bit of irritation in the back of your throat after surgery. So just think about that. Or if my hip and knee and ankle patients, if you can't have a spinal, they will convert to general anesthesia as well. The anesthesia provider can also help you with what are called nerve blocks. And that is where they put numbing medication to the nerve that goes to your surgical site. So once again, I will completely admit I don't like needles, but if I were in your situation, I would have these nerve blocks done. It really does help with post-op pain control. So I want you to have a chance to think about it so it's not a surprise. If it's something that you're anxious about, make sure and talk to the anesthesia provider. I can't remember a patient in years that has not had one done, but once again, just want you to have a chance to know that that may be coming so you have a chance to kind of process the information. Then you're going to go into the operating room. Where they're going to get you cleaned up for the 18th millionth time. You are going to be so clean when you have this surgery. And they will do the anesthesia, whether it is spinal or general. They'll get you all positioned and all those types of things. After you are asleep, if you have a spinal block, they will put in a Foley catheter after you're asleep. So you don't know when it's going in, which is a good thing. So if you are having a total knee replacement, expect that you'll be in the OR for about an hour and a half. Shoulders also about an hour and a half. Hip patients expect around 3 hours, and ankles about 4 hours. Please, though, tell your family members if you're in there a little bit longer, it's nothing to panic about. It just means that maybe they were fighting a little more arthritis or trying to get just a little bit better fit or something like that. Please don't panic. But also realize that not all of that is actual surgery time. A lot of it's getting you positioned, anesthesia, all that kind of stuff. So the surgeries don't take as long as you may think. After the operating room, you'll get transferred to the recovery room, also called PACU. That is when the surgeon will go out and meet with your friends and your families in the waiting room, let them know how you're doing and how everything went. And the nurses in the recovery room will make sure that your vital signs are stable, you're nice and comfortable. If you had a catheter placed, that catheter will be removed right before you leave the recovery room. And it's usually when you're still numb, so you don't feel it coming out. So you're asleep when it's going in and you're numb when it's coming out. That's our plan anyway. Then you're going to go to our 3rd floor. So all of our rooms are private, and our 3rd floor is our orthopedic floor. The nurse will get you settled in, and we will feed you. And if you are a caffeine person, we will caffeinate you as soon as humanly possible because we don't want any caffeine withdrawal headaches. Depending on the time of the day that you had surgery, physical and occupational therapy may see you that day, or it might be first thing the next morning. So our orthopedic floor is the third floor of the hospital. And this is actually a picture as you come off of the elevator. What I love about the third floor is that we also share the floor with postpartum. They have one hallway, we have the other hallway. But because there can be babies on the same floor, there can be no sick or infected people. So that's just another level of protection for you. But because there can be babies on the floor, it's a locked unit because we got to make sure nobody's stealing any babies when they leave. So family members, you're going to see just to the left of the glass by the doorway, there's a black box. This is a close-up of it. So there's a little button there with a camera. And so please press that button and you say, you know, I'm so-and-so, I'm here to see so-and-so, and you will get buzzed in. Just though, family members, visitors, please make sure that you check with the nurses station on your way out so they can open the door for you. Because if you touch the doors, alarms start going off and we don't want that. So this is a picture of our ambulation board. Research has proven over and over again that one of the best ways to help prevent post-op complications, particularly of blood clots or pneumonias, is early mobility. So you're going to be up and walking within a few hours after surgery. And we've got a whole hiking theme on our floor to go with our beautiful mountains up here. And so we have rooms 301 to 310. And so whatever room you're in, you get to pick whatever color hiking boot that you like. And every time that you walk, you're going to move your boot on the board so we can keep track of it. We also have these trees, they're like stickers on the wall, and they're approximately every 25 feet, so you can kind of track how far you've been walking. But I don't know if you remember, one of the things I ask is that you bring some clothes and different things, and that's because we don't want you flashing your high knee to everybody as you're walking down the hallway, so we're going to get you in some regular clothes. So the day of surgery, you're going to be getting out of bed and into a chair. You're going to be out walking in the hallway. Total knee replacement patients, this is super important. Please do not put a pillow underneath your knee. It's going to feel really good to have a little bit of something underneath your knee and your knee's bent just a little bit. But your ability to get your bending and your straightening back or your range of motion after surgery is going to be really important. And I tell you, those last few degrees of straightening are kind of like when you're on a diet and those last few pounds take forever. Those last few degrees of straightening can be kind of ornery to get sometimes. And if you have your knee in that slightly bent position all the time, it's going to be really challenging for you. So please don't do that. It is okay if you want to have your leg elevated on a pillow as long as your knee is straight. That's completely fine. It's also okay if you're sleeping and you end up laying on your side and you have a pillow between your knees. That's okay too. But during the day when you're up, please no pillow underneath your knees. Hip replacement patients, please do not cross your legs after hip surgery. You won't really be tempted to, but we're going to talk more about your hip replacement precautions in just a minute. Total ankle replacement patients, you're not going to be allowed to put any weight on that ankle after surgery. So it's real important that you get your upper body strength kind of built up. Those preoperative exercises are going to be real important for your upper body because it'll take a lot of stress. So hip precautions. Most of our surgeons do what's called an anterior approach. And what's great about that is that it is a muscle sparing procedure. So no muscles get cut and it's an easier recovery for you. But there are a few things that you need to be careful of after surgery. For example, we don't want you to rotate your leg outward past 45 degrees. So if you can kind of picture when somebody kind of walks like a duck and their toes are kind of pointed outward, that's what we're talking about. You also don't want to move your surgical leg backwards. And I tell you where people get into trouble with that is if you're like backing up to a chair, you just want to make sure that you step backward with your non-surgical leg. Don't worry, you will get a lot of education on this, and there's information in your guidebook about it as well. Don't worry, we are professional nags and we'll help you make sure that you don't break those precautions. The other thing to be careful of is no muscles are cut during this particular approach. However, the muscles on the front of your hip get really stretched out and they can be a little bit fragile. So some of your postoperative exercises are going to be leg lifts, and those are really important to do, but I don't want you to go gung-ho and do 842 because that muscle is too fragile and it can't take it, and it could bleed and you get a hematoma. So do what your therapist says, but don't go crazy on him. That's just to help protect you so you don't get blood in that area. Ankle precautions, no weight through that ankle for 6, sometimes 8 weeks. So you're more than welcome to have a friend or family member spend the night with you in the hospital if you like. Each room has their own hide-a-bed, and we've got linens and pillows and things like that. That can be a very personal decision, and everyone feels a little differently about that. But if you would like to have someone spend the night with you, we're more than happy to accommodate that. We would really like, though, that at least one person be available the day after surgery for the therapy sessions, just so they know how to help you once you go home. So the day after surgery is a very, very busy day. So the vampires are going to come by about 5 o'clock in the morning to draw your blood. Then you're going to get up and dressed and walking and moving. Breakfast is about 6:45, and I'm sorry for the getting up so early, but there is a method to the madness. We want to make sure that you have food in your stomach so that when you take your oral medications, you don't get sick and that your medications are kicked in for therapy. So that's kind of why we have the timing the way that we do. So on the 3rd floor, we also have our own therapy gym. If we have, right now with social distancing, if we have 4 or less patients, we can accommodate everyone in our own therapy gym. If we have 5 or more, we have to have 2 separate sessions because we can't keep people 6 feet apart. So most likely you will have therapy at 9 a.m. So we start our parade to the therapy gym around 8:30, give or take. So you'll have your therapy about 9. It lasts around an hour, give or take. Immediately following, the nurses teach a discharge class and kind of what to expect going home, how to care for your incision, things like that. Most of our patients go home midday the day after surgery. If you're struggling a little bit and the therapy and the nursing staff would like you to stay for the afternoon therapy session, that's at 2 o'clock. And for some reason, if you need to stay another night, we're happy to have you, and you're more than welcome to spend another night in the hospital. I will say, though, about 95 to 96% of our patients do go home that day after surgery. So I would kind of err on that side just kind of for your planning purposes. So to help prevent post-op complications such as blood clots, everybody's going to wake up with those lovely white surgical hose on. Those are called TED hose. And I want everyone to write this down. Those hose need to stay on until your follow-up appointment with your surgeon. Then you beg. You say, "Can I please take these off?" And most of the time they will let you. You can take them off to bathe. Please don't bathe with them on. You can take them off to launder them. They dry really quickly though. And then you can take them off, maybe 45 minutes, a couple times a day just to let your skin breathe a little bit. If you leave them off much longer than that, they are going to be even harder to get back on than they already are, and they're kind of a bear anyway. You will also wake up with those machines on your legs that kind of give you a massage. Those are called SCDs. That helps keep the blood flowing to prevent blood clots. Wiggling your ankles up and down. Ankle replacements, your surgical side, you're not going to be able to move it, but please can move the non-surgical side. But the rest of you, please move both of your ankles up and down a lot. That's going to help keep the blood flowing to help prevent blood clots as well. Lots and lots of walking or early mobility will also help prevent blood clots. To help prevent pneumonias, you'll see a picture of that breathing machine there. That's called an incentive spirometer. I just call it breathing machine because it's easier. The purpose of that is to get air into all the nooks and crannies of your lungs to help prevent a pneumonia. So you want to do it nice and slow and steady. So it's more like instead of, if you can tell the difference. Now, I will tell you this really happened to me, and thank goodness my patient had a really good sense of humor. But sometimes people want to blow into the machine, but you want to inhale. And I walked in a patient's room and she was blowing into the machine. And I said, "No, so-and-so, you suck." She turned around and looked at me and she said, "You suck more." So she was totally joking with me. I was very thankful because I stuck my foot in my mouth. But if that helps you remember that you need to inhale, please use my embarrassing story as a memory tool for you. So blood thinners. So this is going to get a little bit complicated because different surgeons do different things. So I'm going to talk about doctors Oldham and Cornelsen first. So Doctors Cornelsen and Oldham prescribe a medication called Lovenox as a blood thinner. And this is an injectable medication. They feel very strongly about this medication and really want you to use it. Okay, for doctors Brimhall and Regan, they usually use an oral medication, either Xarelto or Eliquis. These prescriptions can be very expensive depending on your prescription drug plan. For most people, these blood thinners of the Xarelto or the Eliquis are in the $200 range. Now, for all of you, for all the different surgeons, we really want you to have your prescription of your blood thinner before surgery. That way, if there's a problem or it's cost prohibitive, we can figure out what the next plan is going to be. What I don't want to happen is I don't want you to leave the hospital, have your prescription for your blood thinner, you go to the pharmacy and you can't afford it and you don't fill it and you end up with a blood clot. If you haven't had your pre-op appointment yet, just make sure and remind them when you have your pre-op appointment to give you that prescription. Okay, so I'm going to revisit this topic again. You do not want to take these blood thinners before surgery. We will give it to you when you're in the hospital. You just leave these at home, and these are after surgery only. Do not take any blood thinners before surgery, or you're going to have your surgery canceled, okay? I don't want that for you. So preventing post-op complications such as infection, we're going to be monitoring your vital signs frequently, looking at your incision to make sure that it's not hot, red, those types of things. Also giving you the total of 3 doses of IV antibiotics. Most people don't have problems with nausea and vomiting, but if you do, we have medications that are ordered for you that we can give to you. I will give you a piece of advice though. Where people get into trouble with the nausea and vomiting is like that middle of the night pain pill time, and they take it on an empty stomach. That can get you in trouble. So we have like saltines, graham crackers, nuts, different snacks that we have that we can give you. So please make sure you always eat something when you're taking your pain medication. Constipation is most likely going to be a problem. So we will be giving you medications for it when you're in the hospital, as well as sending you home with medications for constipation. If you go home and haven't had a bowel movement in 3 days, we need to go to plan B because I don't want you to end up in the emergency room because you're constipated. So if you need help figuring out what plan B is, you can talk to your surgeon, you can talk to your primary care. We're kind of beating this dead horse a little bit, but early mobility helps prevent almost all of these complications. So it's going to be really important that you stay up and you stay moving. There's a picture of a recliner there. You're going to spend most of your time in the recliner and not in bed when you're in the hospital. I think that you realize that there's going to be some pain associated with the surgery, but it's, even though it hurts, it's almost a relief because you're like, okay, this hurts, but I know I'm going to get better. I know I'm going to get my life back. I'm going to get back to doing the things I want to be able to do. Our goal is to keep your pain about a 4 out of 10. If it's greater than 4, you can't walk, you can't talk, you can't sleep, you can't eat. I'm going to talk about our pain management protocol, and I'm going to talk in generalizations because we're not going to give you something that you're allergic to. Um, these medications work well individually, but when we combine them together, we find that we have a lot better results. So we use a medication called Celebrex, which is an anti-inflammatory. So it's addressing the inflammation that happens from the surgery. We use a medication called gabapentin or Neurontin, which is a nerve medication to help calm those nerves down after surgery. We use Tylenol as an analgesic. We also use a medication called Flexeril. Flexeril is a muscle relaxant, so if the muscles are kind of angry and upset after surgery, it helps calm them down. A side effect of the Flexeril, though, is it can make people really sleepy, so sometimes that's a better one to add to your night routine than during the middle of the day. We will also use an oral narcotic. Now, which oral narcotic we use will depend on everyone's individual medical history. If someone has never taken a pain pill in their entire life, they will need less medication than someone that's been on a significant amount of pain medication. So we have to play that one by ear a little bit. But we really want to try to find an oral combination of medications that's going to work for you before you go home, because you won't be going home with IV medications. If your pain starts to escalate, please let your nurse know. If your pain gets out of control, it's going to take more medication to get it back under control. However, your pain might be starting to increase a little bit and you let your nurse know and they're like, I'm so sorry. It's just not quite time for another pain pill yet. Let's try going for a walk or maybe do some of your exercises. And you say, you want me to do what right now? And your nurse is not trying to be mean. We actually have a saying on the floor. We say, motion is lotion. That new joint needs motion in order to stay lubricated and in order to stay healthy. So it actually feels better when you get up and you move it. So we're not just trying to be mean. There is a method to our madness. We also use these nice big cold gel packs to help with the pain and the inflammation after your surgery. So we unfortunately do not get to go home with those, but if you can get them at a lot of pharmacies or Amazon, the hospital's pharmacy at the outpatient pavilion also stocks them there. You can make your own out of 2 parts water to 1 part rubbing alcohol. And you can put it like in a freezer Ziploc, but you might want to double or triple bag it so it doesn't leak on you. If you're under a pain contract, you should know what that is. If you have a pain contract, please let your pain provider know that you're having this surgery because we don't want the surgery to kick you out of your contract. If you don't know what a pain contract is, most likely you're not on one and you don't need to worry about it. Just remember, we can't make the pain go away completely. Our goal is to keep it about a 4 out of 10. So you can walk, you can talk, you can sleep, you can eat. It is very typical to have bruising after joint replacement surgery. There's just a little bit of blood loss during surgery, and it's going to take a couple days for it to maybe make its way to the surface. And that bruise can kind of move around on you. It's just the blood getting trapped underneath the tissues and moving. It's nothing to panic about. However, your pain, swelling, and bruising is most likely going to peak about day 2, day 3 after surgery. That is the body's normal physiological process. So this is after you've gone home, and I just want you to be aware of that so you can kind of be just prepared. Okay, I'm going to have a rough day or two after I get home, but then it'll get better. People love to blame the swelling and the bruising on those surgical hose, those TED hose, but it's not the hose's fault. So you need to keep wearing the hose. Knee replacements, expect difficulty bending and straightening your knee. Expect difficulty activating the thigh muscle and lifting the leg. That's because the incision along the inside of the kneecap we talked about. You will feel a lot better, but you're going to have swelling that sticks around for several months. So just kind of expect that, or your first trip off mountain, or maybe your first time kind of working out in the yard a little bit more than normal, your knee may kind of balloon up on you, and you're just going to elevate it and ice it, and it will go back down. But that swelling kind of sticks around for several months, so it's nothing to be worried about. It is kind of normal, but just so you're aware of it. We're going to talk more about therapy in just a minute, but expect approximately 2 to 3 months of outpatient physical therapy. Hip replacements. Expect difficulty activating the thigh muscle and lifting the leg, just because that muscle on the front of the hip got kind of stretched out and is a little bit angry at you. Because the anterior approach is muscle sparing, it's a little bit easier rehab for you. So expect approximately 1 to 2 months of outpatient physical therapy. Ankle replacements. You're not going to be able to put weight on that leg for 6 weeks. About 3 weeks after surgery, when you have your post-op appointment, your doctor will let you know when you can start moving that ankle and doing some range of motion exercises. And then expect approximately 6 to 9 weeks of outpatient physical therapy. Shoulder replacements. You're going to be in that sling all of the time except for when you do your exercises for the first 2 weeks. And then you will be referred to outpatient physical therapy, and expect approximately 2 to 3 months of outpatient therapy. The rehab for shoulders can be fairly extensive because we have to do so much with our arms, especially overhead, brushing teeth, combing hair, all those kinds of important things. So we're going to talk more about therapy. So this pertains to our hip and our knee patients. If you would like and you live within about an hour of the hospital, in most insurances, we can arrange to have a therapist come to your house for the first couple of weeks. Some people prefer that, just makes it a little bit easier. Some people prefer to go straight to outpatient physical therapy afterwards, and that's completely fine too. I want you to refer to the handout. This is Community Resource Guide. There are all of the outpatient physical therapy clinics in the general area. I want you to start thinking about where you want to go to therapy and letting them know you're coming. So that applies to all of you. So if you're going straight to outpatient physical therapy for hips, knees, you're going to want to call your outpatient physical therapy, let them know when your surgery is and when you need to start therapy. If you're going to hips and knee patients, if you are going to have a therapist come to your house for the first 2 weeks, I want you to still call the outpatient physical therapy clinic and let them know when to expect you. So about 2.5 weeks after surgery, you would want to schedule your outpatient physical therapy clinic. Ankle patients, if you want to go ahead and let a therapy clinic know that about 3 weeks post-operatively you will need to start therapy, that's completely fine. Shoulder patients, you will start outpatient therapy after your follow-up appointment, which is around 2 weeks. I highly recommend that you figure out where you want to go to therapy and let them know that you're coming. What I don't want to happen is I don't want you to be waiting weeks to get into outpatient physical therapy. So I want to be proactive about it. If you decide to have a therapist come to your house for the first 2 weeks, the case management department will set all of that up for you when you're in the hospital. So you don't need to worry about any of that right now. But I want you to be thinking about your outpatient therapy. Going home. If you live longer than about an hour's drive from the hospital, you maybe want to think about stopping at the hour mark and getting up and kind of moving around the car, because you could get kind of stiff and uncomfortable, and it could be a higher risk for blood clots as well. So about the hour mark, you might want to get up and move around. I want to talk about your incision. So when you're in the OR, they will suture all of the deep tissues together, but your skin is going to be held together by a medical grade superglue. That's called Dermabond. And then over the top of it is this clear mesh. It kind of looks like a window screen, and it can be a little bit hard to see. Our nursing staff will make sure that you know what it looks like before you leave. But that Prineo, or that screen material, is what's holding your incision together. So what's great about this product, it's waterproof. So you can shower about 36 hours after surgery. Our nursing staff will go over all of that before you're discharged from the hospital as well. But that does not mean that you can get in a swimming pool, a bathtub, take a polar bear plunge in Holly Lake, none of that, but a shower is fine. You don't want to use any lotions or ointments or anything near that incision either. When you have your follow-up appointment with your surgeon, which is usually around the 2-week mark, they may decide to remove that. Or they may say, just go ahead and let it fall off on its own. If kind of the corners kind of come unloose, feel free to trim that so it doesn't kind of get caught and tug and pull on something. However, if it's not off by about week 3 after surgery, you may want to consider taking it off. I had a gentleman that took me really seriously, and he called me about 6 weeks after surgery, and he's like, Ange, I'm getting a rash, and that Prineo still had not come off. I'm like, oh, we got to get that off of there. So if it's on for more than 3 weeks, you may want to consider taking it off. In the first couple of weeks, if that Prineo comes off accidentally or accidentally on purpose, call your surgeon's office. They may want to put some Steri-Strips on, or they may want to put another Prineo on. Most of you will not really have much drainage from your incision, but for knee patients, we will use a cotton pad over your incision that's held in place by those white surgical hose, and you'll wear that for a couple of days. Hip patients. So we have 2 different choices. One is we've got this big Band-Aid kind of looking thing, but some people don't react well to adhesives, and especially the hips tend to get kind of swollen, and your skin can blister a little bit easier. So our other alternative would be if you wanted to get kind of like some cotton biker shorts or something like that, that we could hold the cotton pad in place. That's another alternative as well, and it will just be for a couple of days. But that's kind of up to you. So we can use a big Band-Aid kind of looking thing, or we can use just a cotton pad held in place by some tighter shorts. Shoulder patients, we don't have too much of a choice with you. We're going to use the big Band-Aid kind of looking thing, and ankles as well. Ankle patients, you're going to have several smaller incisions just based on how they have to access the ankle during the surgery. Once you go home, you cannot become a test pilot for Barcalounger or La-Z-Boy. Okay, it's really important that you do your exercises. You know, we want you to get your life back. We want you to be out of pain and be able to do all the fun things. And if you don't do your exercises and put in the time and the effort that you need to, you're not going to have a good outcome, and you're still going to be in pain. And who wants that? Who wants to have gone through this big surgery and still be in pain? So it's really important that you're mentally, psychologically prepared to really put in the work that you need to have a good outcome. Once you go home, you're going to take your pain medicine as prescribed. We're having problems with some prescription drug plans where they are only authorizing 5 days of pain medication at a time. The surgeon may write for 2 weeks worth of medication, but the insurance says you can only have 5 days at a time. If that happens to you, just call your surgeon's office so they can reauthorize it, and you can pick up the subsequent 5 days. So if that happens, just coordinate with your surgeon's office. When you go home, take the medication for constipation. If you haven't had a bowel movement in 3 days, we need to go to Plan B. And then you're going to resume all of your regular medications. When you go home, that's when you're going to start taking the blood thinner, not before. Dental work. So we really want to make sure that you have any dental infections cleared up before surgery. Mouths can be dirty places, and even when you go in to get like a routine cleaning and we bleed a little bit, that is a place for bacteria to enter your bloodstream, and it loves to settle in artificial joints. So we also ask that you do not have any routine dental work like cleaning for the first 6 months after surgery. After that, your surgeon wants you to pre-medicate with an antibiotic before dental work. And that just usually means taking 1 or 2 pills like an hour before your dental appointment. So you've got that antibiotic in your bloodstream so that if a bacteria enters your bloodstream, that antibiotic kills it right away. This is a very controversial subject. Some dentists say that you don't need to do this, but your surgeon wants you to pre-medicate with those antibiotics. Okay, this is for the rest of your life. Your surgeon would be happy to prescribe those medications for you. So you just need to call them up, be like, I had a joint replacement surgery, I'm having dental work, can you please call in a prescription for me, okay? So your recovery is going to be a little bit like the bunny hop. Sometimes it's 2 steps forward, sometimes it's 1 step back. Just kind of be prepared for that. It's going to kind of be up and down. I highly recommend that you think about what you could do a week ago. And you're like, gosh, last week I couldn't do such and such, and look at what I can do now. And focus on those positives and all the gains that you're making. Do your exercises. I think we've talked about that already. Obviously, eating healthy will promote healing, and any type of nicotine use is going to slow down your healing. I am a realist and realize that asking people to quit using nicotine is not going to be very popular. But if you can minimize the amount of nicotine that you use after surgery, it will help with your healing. So if you can't quit, at least try to cut back as much as you humanly can.